Thank you for impressive talks, food for thought, and you know, we are a little bit, but we have time for some comments and questions from members of the forum on the 4 talks. So I'm looking at it while you're seeing, I could say that, all right, let's go straight to the members of the forum. Jay.
Dr. Wood, you know, where I live, just a few miles from here in Bethesda, there's a county building code that doesn't require air exchange. In fact, it caps it. So you build a new home and you have to do a sealed door air pressure test to make sure that the home is airtight, minimizes gas exchange since that decreases energy consumption. And I know anecdotally that those construction codes have led to increase in sick buildings and buildings in which there are, you know, carpeting or insulation that are degassing volatile organic compounds. Are such building codes then in place in South Africa anywhere? Are they increasing in the US or elsewhere infectious disease risk?
Just a comment. You have had in the States some extraordinary effective contact numbers of kids in schools. So I think the potential for transmission has increased. I think you had a Colorado epidemic where 240 people were infected from one person, pointing out the super spreader story. I think part of the problem is that we have never given the architects medical reasons for not decreasing the ventilation. So they do smell tests and they do sick building syndrome and they do energy conservation, and you can't really blame them. We've never told them what the problem is with disease. And I think that's a lesson. That's why it's got forgotten to some degree. Interestingly, the building codes in South Africa give an area of the floor area that has to be opening. But interestingly, Pollsmoor Prison, with 300 people in one room with no ventilation, has exactly the same building code as my bedroom at home. So, you know, there's some idiocy there as well. But the basis of your point is that there are other factors that need to be taken into consideration as well. But I think we've failed to tell architects what's important from the health, and because there wasn't any data on it.
David?
Thank you. I just wanted to ask this panel, but also more generally, in a way, why it's taken a bit of time during the conversations today to focus on people who might be spreading rather large numbers of pathogens, either in their coughs or in other modes of transmission. It seemed to me that the super spreader issue was something we ought to really be looking at in every single thing that we do, whether we're talking about cholera or talking about influenza or talking about tuberculosis. And we just would like to ask these panelists, but also others in subsequent conversation, if we could spend a little bit more time thinking about the significance of these extraordinary individuals and the degree to which it's them, the key individuals who are secreting a large amount of pathogen, who probably are more important than the many other factors we've been looking at today on pathogen transmission in built environments.
Want to take this first? Robin.
Yes, I think super spreaders are important. I think that depends on the disease. I have been measuring the infectivity of individuals, TB individuals, and finding out their production rate of appropriate sized particles. And part of the problem with that is that we have only found super spreaders historically because our sensitivities of our systems for finding them are so low. So you actually need to define the problem properly as well by having the appropriate sensitive systems. But I think it's very disease specific. But I think part of the control that you saw in New York is that of the spectrum of people, with a lot of people with low infectivity and a few with high, you've been left with the high ones because the others can't transmit. I think in our circumstances, everybody's transmitting. If I look at the number of strains of TB in this community, it's over 500. So it's not a single super spreader. We've got a situation of endemic TB spread, but I think the situation's very different in other places.
To add another is that I think most times that we identify super spreaders, it's post hoc rather than pre hoc, and it really gets at the issue of nonlinearities and heterogeneity and the issue of signal. How do you sample for a super spreader? So I mean, I think we do it retrospectively, but then what's the attributable fraction of that, super spreader that's been identified post hoc?
Just to add a bit to the super spreader, in cholera it's quite difficult. I'm not sure how you might look at that. So it does have something to do with the host, right, and how infectious they are, but also the social context as they mentioned. So how many opportunities do you have to spread? And sometimes in other diseases I study, it seems to be when the stars align for those. So reducing either could help.
Thank you. Peter?
Yeah, and in addition to that, I think you've got to look at the mechanism for super spread, and that's what you get basically saying. Once you get the mechanism, then it has some value. But I want to ask a question to you, Emily and Albert. First of all, what are the interventions? Because where do you go with the cholera work? What's going to be the new intervention based on knowing more about where these cases start? And is it to do with the environment, or is it to do with treatment? And then for Albert, these rats fascinate me because, New York, we've got some great rats there, but that's New York, which I've heard is the greatest city in the world. That's what I've been told. And we can't get rid of rats. So what is the solution for rats in the favelas in Brazil?
All right, so I'll go first. Where do we start? The goal of getting people safe water to drink is a long-term goal that we should pursue doggedly, or we'll never make more progress. So that's there for a lot of reasons beyond cholera. So I don't think that's cholera specific. But I think for cholera, we have a good vaccine now, and we should be using it more than we are. I think that often our vaccine strategies are based on administrative unit rather than high-risk area, high-risk population, and a lot of the intervention strategies and systems we have aren't flexible enough to take those into account. But I think if we can get more flexible in where we deploy, we can deploy more quickly things like vaccines to reduce hotspots of risk. And because if you can shut those down early, you probably reduce risk for everyone. So I think there are good interventions, but we have to get a bit smarter about how we use them if we're going to be really successful.
Can I just jump in? Yes, go ahead, David.
You said water. You don't think sanitation?
Yes, I think, I guess I'm thinking water because probably cholera spread through contaminated hands probably happens within the household. So what you need first is someone in the household who's infected, and they're probably getting infected by water. So I'm thinking more upstream, but I think obviously sanitation's a part of that, but that's also water related because you need good access to water to wash your hands. So maybe sanitation, you're talking about a good toilet. Certainly you need good infrastructure, but I think keeping water clean would go a long way.
I just want to share with everybody, I'm super obsessed by the delay that we've had globally in advancing sanitation, and I'm anxious that sometimes in the water and sanitation goal 6 in the SDGs, people always put water first. And yet, it just seems to me, perhaps it's just wrong logic, that as public health people, we need to be pushing for better sanitation. May not be water-based sanitation, but separation of feces, particularly children's feces, from the environment to try, and particularly during the rainy seasons. Perhaps we could talk about it tomorrow, but this seems to me to be a really key issue in the built environment.
No argument for me on that.
I just want to check. Peter, were you two questions? You had
Can I-
another question for Robin. Yeah.
Just as far as the control of TB is concerned, one of the things that I didn't touch on really is the role of the TB control program is to try and decrease the prevalence. So obviously that period of prevalence makes a big difference. So if you've got very poor ventilation systems, such as in prisons, you have to identify cases so fast that you actually, what it tells you is your TB control program has to be tailored to the social circumstances. So if you have a group of people, HIV, that are progressing fast or that are living in poor circumstances, you can't use the same passive identification of cases that you would do normally. So part of this analysis is that you have to have more active case finding, looking for the cases when social circumstances are bad. And interestingly, in Cape Town, we did that in the 1970s. We did 5 million chest x-rays, and that was the lowest point of our TB epidemic, but we were told to stop it because it was no longer cost effective globally, whereas in fact I think it was for us.
Thank you. Let me throw a question to Frank on Ebola. You know, one of the issues that talking about slums, the West Point, it's probably the largest slum in Liberia. And while the international community speak about 11,000 deaths of more or less, one of the conclusions of a report I read was that the number of people who died will never be known, because in West Point, the slum was so complicated to deal with that they were even throwing and disposing bodies, not counting bodies. You know, can you comment on that? And the other issue is, it was so quickly contained in Nigeria, and Nigeria in Lagos is just a huge city also. So if we're going to talk tomorrow about interventions, there is a lesson there, Nigeria versus Liberia regarding slums and big cities, because also that Lagos is it's a poverty city, you know.
There were a lot of occult burials. I think people were going out to that island and burying people out on an island outside of West Point too. It was quite extraordinary. I thought one of the striking things about West Point to me, though, was that it didn't spread the way you would think geographically. It was very tight. The outbreaks were geographically very tight. So you get a cluster around a household in West Point, but it didn't spread beyond that household. So the exposure was very family related and very tightly. And it didn't have anything like cholera would spread through it. And then you'd see another outbreak in another part of West Point. Again, very geographically clustered. So I thought that was, to me, very interesting, that the Ebola doesn't move through an urban slum the way you would think of other infectious diseases. I think we were lucky in Nigeria. I think one of the things that, we had the right people at the right time. This colleague, David Brett Major, was there to help mentor clinical staff. I think I didn't tell the whole story of all the critical issues there in Nigeria. There was a doctor strike, and we had trouble finding physicians to manage patients. We at one point, we had a contact show up in another city, and they called and they said, we have PPE, we're going to see this patient. And we just made the right decision. We said, no, you're not. You're not going to see that patient. You lock the door, and we're going to send experienced people that know how to manage an Ebola patient, and we'll bring that patient. It was an 8-hour taxi ride to get back to Lagos to bring that contract in. And I think that what I thought of, right around that time we had that outbreak in Dallas, and I was thinking, there's something to that the people that are managing these people need to be mentored with experienced people. And we were just very fortunate to have experienced people as part of the outbreak. Second thing, I think the FETP there did a great job on doing the contact tracing. And then we also had were able to bring in the polio incident management team to manage the outbreak response. And they had a very good infrastructure of data-driven management, following, we learned so many lessons. When people came in and got sick, and with Ebola, and they reported they'd been febrile for 3 or 4 days. And we said, but wait a minute, we've been doing daily contacts. How come we missed that? And it was like, oh, we forgot, we're working in Nigeria. You have to do, people will make up things. And so we learned that we needed to do directly observed daily contacts. So people were going to the houses saying they took the temperatures when they didn't. And so we learned that we had to do directly observed temperature monitoring of contacts. And so I think we were quite lucky, but I think that we had the right mix of people on the ground at the right time.
Thank you, Chris, and then I'm going to go outside the forum because time is running out, so we need to close.
Thank you. Very nice presentation. So I was wondering, one thing that caught my eye was the environmental sampling for Leptospira, and then thinking back on some of the history of doing some environmental sampling for cholera even. And so for some of these environmentally transmitted organisms, with new technologies, we may be able to do more and more sensitive types of environmental sampling. Air is particularly tough. It disperses so fast that the detection sensitivity is. But I just wanted to ask if you think that there's more in the way that we should be taking advantage of in environmental sampling, giving new technologies.
Sure. No. That's an excellent point, and it's a critical research need. There's several drawbacks. So of course the technology is getting better, but I think there are two big barriers. One is the issue of volume in the infectious dose. So if you're working with, let's say, toxo or cryptosporidiosis, or the infectious dose is very small, you're still having to work with 40 liters of water or 20 liters of water. So that's a big issue. And the technology, so the detection, much of the advances in technology have come in detection, but not in really processing. The third problem is then, okay, you have the apparatus, how do you use it? And what's your sampling design? So if you're looking at very highly stochastic processes, and going back to leptospirosis, probably exposures are highly probabilistic. And so how dense do you have to sample in order to get a noise? And if you get or get a signal, and if you get the signal, is it above the noise in a spatial grid? So those are kind of the key challenges that face that, at least from our perspective.
So, we have been sampling environments. Part of the problem was touched on by Prof. Lee earlier, that large droplets fall out of the air, so you can find evidence of TB on floors and walls. And I think you've been doing that in Brazilian prisons. So it's not difficult to find, but what's its relevance to transmission, we don't know. But we've used some biodefense machines which are used for sampling large volumes of air, cubic meter per minute, which are used, I think, on US warships to pick up that. And we put that into churches, community settings, and into health settings. And certainly we do get positive signals from that using PCR. Again, what the relevance that is to transmission is the problem, but certainly it can be detected. And we're hoping particularly for the kids, because it takes a while to get the results back, and you need to know which population was there. Kids are really good because they're in the classroom and we know who they were, and we can go back and sample them afterwards. In a church, it's a little bit more difficult, but certainly it's something we're trying to work on.
Maybe I can just add a quick issue to that is that, so we're delving into many of the problems that are environmental health. We're very much locked, at least in terms of pathogen sampling, into risk assessment, rather than linking those risks or the environmental signals that we have to, and this is just to reinforce what Robin was saying, to human outcomes. And I think that's the battle that we're facing.
Go ahead.
I think the one exception, I think with polio, they've worked out quite well, environmental sampling and tracking chains of transmission due to the genetic clades. And so I think it's one example where environmental sampling has advanced quite well, and it's probably unique to the poliovirus, though.
One or two questions from non-forum members, and then I close. Yes, please. There is a microphone in the back. Yeah.
I'm interested to know how it can be that in Bethesda in South Africa, that public health information is not communicated to building regulation.
You can think about it. Anybody else want to ask a question while they think?
Would that be Professor Lee? Shouldn't he be answering that question?
Chris, you want it, and then we wrap up.
It's a comment or a question to Emily, if I may, and it amplifies what David has already said, because I think it's such an important point. You started with John Snow. John Snow fixed the water supply. He didn't say, let's do active surveillance. We seem to be extremely reluctant to get into the business from the health community of water and sanitation. We seem to stick in the health domain. Just tell me if you think that's wrong. But before you answer, let me refer also to the excellent point you made right at the beginning about safe water and sanitation. It seems to me that that is really the huge advance in the SDG framework, because the word safe there necessarily ties health to water and sanitation in a way that didn't exist in the MDG era. And that gives us surely an opening to get into the business of really improving the water supply and sanitation. What do you think?
Sure. Well, in John Snow, I don't know that he fixed it. He sort of cut off the water supply for a while, and then they worked on it. Yeah. I think the emphasis on safe is really important. And I think that going forward, if we're going to do that right, we have to incorporate some ground truthing into that. So rather than just say, this person told me this is their water source, therefore their water is safe, I think that we need better ways to measure that safety. Surveillance for cholera is one way to do that, but I'm sure there are many others, but I don't think that we're good at it yet. But I don't disagree.
All right. We're done, no? Yes. Let me just say a couple of words. What these 4 talks tell us is, to me, basically, it's telling us about the importance of the international health regulations, the global health security agenda, on making sure countries implement these essential public health functions in order to contain outbreaks and emergencies. But it's also telling us about the beauty and the need to, how research is giving us some answers on drivers. And we saw it in the presentation of Albert, of Emily, all of them, basically. So there are issues that this forum can say about some of these areas, but there are other issues that are related also to more systemic, and I do believe that we can talk about both. When you talk about rainfall, climate change, housing, these are issues that are very related to the Sustainable Development Goals, and in supporting that, we might make progress. But it's also important that we keep pushing for research, and it comes to me the argument of Chris when he said how many billions in Ebola were invested in just few tiny amounts in research to answer several of these questions that you guys are answering. So with that, I think it's time to close, and I'll pass the word to Mary for wrap up. Thank you very much to the 4 wonderful presenters.